So thank you, thank you. And again, good morning, good afternoon, and good evening to everyone joining us from around the world. It's my distinct pleasure to welcome you to this important and timely webinar on innovative financing for global cancer control, convened by the Global Health Catalyst. And for those who might be new to the GHC events, the Global Health Catalyst was founded at Harvard. That was over a decade today, this year. So this year, the GHC is celebrating 10 years of incredible work that has been done. And it was during this decade, it has served as a bridge between academia, health systems, governments, diaspora communities, research, and treatments, name it. And through its mission to catalyze high impact collaboration, it has helped strengthen cancer control initiatives, support policy innovation, and advance equitable access to care in low and middle income countries. And over the years, the Catalyst has contributed to meaningful progress in terms of expanding access to radiotherapy, supported the training of health professionals, strengthened international research collaborations, brought together local partners at the same table, and it has played a central role in the early steps toward a global cancer fund, and which is a promising effort now being led by Dr. Catherine Young, who will be one of our speakers today, to raise long-term funding for cancer control efforts worldwide. But these achievements show that what is possible when people and institutions work together. They also remind us that funding remains one of the biggest obstacles to progress. And we've heard this over and over again in all the initiatives that the GHC has been a part of. And I mean, these summits have not just been in the United States. There's been satellite summits in Africa, in Bangladesh or Asia, Eastern Europe. That's how wide the scope of the GHC is. But one of the recurring themes has been limited funding, not just for the research and treatments, but also for access to care for we, the consumers in healthcare. So today's conversation is really a continuation of a momentum that was picked up during the last a few months, actually. We had the HOPE Summit earlier this year, and Her Excellency Robi Kakonge, the ambassador of Uganda, had a presentation on the importance of diaspora remittances in supporting national health systems. And her remarks helped shift the attention as well to financing approaches that tap into the existing community support networks and combine them with tools that can bring greater accountability and impact. So we are now at a point where we must look beyond traditional aid and ask new questions. How can we turn ordinary remittances into long-term investments in health? Can we design tools that allow people in the diaspora to directly support cancer care for their families and communities? How can technology help us make these processes more open? So financing is one of the most critical but often under-addressed dimensions of global health. So it's no longer enough to just focus on the innovation, the treatment, diagnostics, without building the sustainable and inclusive models for financing these solutions. So whether through diaspora bonds, health-saving tools, global fund mechanisms, we have an opportunity today to explore how we might unlock our new capital for good, starting with cancer, non-communicable diseases. How can we make them more secure? How can we make them more effective? So this webinar brings together a remarkable group of people from finance, health, policy, and each of them will offer ideas, lessons, and examples that can help us move this discussion to action. Uganda is going to serve as our case study for today, but the goal is broader: to help shape financing solutions that can work across Africa and beyond. Thank you for being here. And each and every one of us is a stakeholder. Part of my, what I took away from my experience in Uganda working with the National Planning Authority back in the days was that it is very, very critical to engage stakeholders, not just at a policy level, but even the implementing partners, and we are all implementing partners in this process. So thank you again for being here. We invite you to stay engaged through the conversation, pose questions, the most difficult questions, and think creatively about your role in this shared journey. But to kick us off, I would like to introduce our first speaker to give us, her opening remarks. And this will be Her Excellency Ambassador Robbie Kakonge, Uganda's ambassador to the United States. But before I even get one thing about her, she's not only an ambassador to the United States, she is a non-resident ambassador to various countries: Argentina, Bolivia, Brazil, Chile, Colombia, Ecuador, Jamaica, Paraguay, Peru, Trinidad and Tobago, Uruguay, and Venezuela. Man, that's a lot to carry. But she's also accredited to global financial institutions like the World Bank, IMF, and as well as the International Telecommunications Satellite Organization. So with that introduction, over to you, Ambassador Kakonge, to give us your remarks. Ambassador, you're muted. Oh dear. Did we lose the ambassador? Well, as we wait for her, yeah, we'll just give her a minute. Anyway, I think she fell off. She was traveling, so maybe she lost her connection. But as we wait for the ambassador's remarks, we're going to then cross over to Dr. Young. And this is because, like I mentioned in the introduction, Dr. Young has been a champion for health, for global health, for cancer control. She worked at, maybe just to give you a background of who she is. She's currently serves as a senior fellow at Harvard C.T. Chan, that's School of Public Health, and is a globally recognized leader in innovation and health policy with a track record of scaling transformative initiatives. She mostly served as the Assistant Director for Policy and International Engagement for the Biden Cancer Moonshot at the White House Office of Science and Technology Policy, where she shaped the national and international cancer strategies, launched federal policies, and secured a multi-billion-dollar commitments. She is a great person to have, a partner to have in this. And not only that, she might look different from many of us, but she's a daughter of Africa. She was born and raised in South Africa. So over to you, Dr. Young. Please give us your remarks.
Vivian, thank you so much for that, and also for your incredible opening remarks, really kind of laying the foundation of today's conversation, which I will build on slightly, as you mentioned, around the creation, design, and launch of a global cancer fund. And if it's okay, I'm going to share a few slides. So I'm going to go ahead and do that. Okay, let me see if I can play that. So I'm very excited just to share a few remarks. I know the ambassador is also going to be sharing remarks, so I won't take up too much time in case she joins back again. But really the point of my remarks today is share a little bit more about the creation of the first ever global cancer financing platform to really start to close this cancer equity gap. Now, we all know what happens when we see very committed financial commitments to a disease. And we've also seen what happens when political will and social will come together, and the changes that can happen because of that. But when it comes to cancer, we've never had our own Gavi. We've never had our own global fund until now. Now, why is this so important? Because as everyone knows on this call, cancer is rising the fastest in low and middle income countries, where over 70% of cancer deaths now occur. And yet, despite this really staggering statistic, low and middle income countries and cancer receive less than 5% of global cancer resources, which just doesn't make sense. So the question has always been, particularly in the last 2 decades in this community, why have we not had our own dedicated global cancer fund? Because the result is that a woman who is the same age as a woman maybe in sub-Saharan Africa or in India, if they both detect a lump, the woman in Chicago, for example, will receive treatment almost immediately, and her chance of survival over 90%. The other women in low and middle income countries, their prognosis is probably a stage 3 or 4 diagnosis. And oftentimes that's because the diagnosis comes too late or not at all. And their outcomes are completely different. So we absolutely believe that the time is now to reimagine global cancer financing so that everybody, regardless of where they live in this world, has the same opportunity to live to their fullest potential. So what is the goal of this creation of a global cancer financing platform? It is to mobilize $1 billion in committed and leveraged capital by the year 2030, and it will be centered on stage shifting. In other words, catching cancers earlier in low and middle income countries, starting with women's cancer. So this approach allows us really immediate and measurable impact while building long-term infrastructure that is required in order for us to tackle all cancers. Now, cervical and breast cancer make a logical launch point for this work. It is an actionable entry point because it is in strong alignment with the many global initiatives that already exist for cervical cancer elimination. But also with breast cancer, we can build on the infrastructure, the screening platforms, the health work training, the diagnostics to really create synergy and scale. And I think most importantly with this, to treat women as a whole and not simply as a body part. And that is why we're combining both the focus of cervical cancer and breast cancer together. So the Global Fund's strategy, as we've been thinking about this blueprint in the last 8 months or so, really distinguishes between two categories. The first are immediate investments, which are going to be really essential to the fund's launch and focused on near-term and measurable impacts. So this will focus on early detection, prevention, diagnostics, and screening for cervical and breast cancer, as well as looking at both the resources and tools that already exist. How do we ensure deployment of those to the people that need it the most, but also focusing on technology that can rapidly help us achieve progress. And then there will be phased platform enablers. These are complementary investments that will build the delivery ecosystem and reduce future cost, but also ensure expansion and scaling of this work. Now, ultimately, this fund will be focused on a group of 5 to 7 countries, which will allow us to demonstrate results, refine the implementation model, and also build momentum. We have to start somewhere, and the lessons learned and the systems that are strengthened through these first partnerships will really allow us to broaden and scale outwards to additional low and middle income countries. Just a quick word on the essential enablers I mentioned about this platform. So we've identified 5 different categories. First and foremost, of course, technology and innovation. This is really going to be key to making sure that we are building towards a future that incorporates the amazing technology and innovation that exists and those that are currently being developed at this point. We also want to make sure that this work is completely aligned with national control plans. So unlocking either plans that are in development or underutilized plans with targeted technical assistance and co-financing. Of course, market shaping could be a very, very influential power in aggregating demand and reducing costs for diagnostics, therapeutics, and vaccines. What we know for sure, based on so many of our conversations, is that we cannot do this work without increasing workforce capacity and building. And so partnering with already existing initiatives to really close these critical gaps when it comes to oncology providers and workforce will be an essential part of this work as well. And importantly, we don't want to exist as another silo or work that duplicates or competes with already existing work. Rather, the approach that we're taking is a very intentional one to ensure that we integrate with existing infrastructure. So leveraging platforms that already exist and have been built by PEPFAR and Gavi and the maternal health initiatives to really be able to scale and to create sustainability with this work. So what does this financial strategy look like? Just really briefly, we are not pursuing a traditional replenishment model, and this is really key to long-term sustainability with this financing. The idea is to launch with about 50 to 100 million in seed funding, and this could come from philanthropic leaders and organizations. We could anchor this work through the multilateral development banks that will be a very key partner in this. But I think excitingly and more importantly is the innovation that lays in understanding where are these pockets of funding, and we're going to probably be talking more about this today in more detail around the innovative financing mechanism that this platform can capture in totality. The diaspora bonds, the remittance platforms with health-linked contributions, and advanced market commitments and blended finance will be so important in this work to ensure that we're not relying on just one mechanism, but that we're diversifying out to be able to capture as much funding as possible with this. And of course, I think also importantly is we need to embrace the technology of today to build for the future of tomorrow. And that includes ensuring transparency in this work, for example, utilizing digital ledgers to build trust in the system. And I think that is going to be a really key component of this. So just briefly and in closing, we are standing at this inflection. We know that we do not need extra science, extra tools, extra resources. They already exist. What we lack is the platform to pull these threads together and turn really fragmented efforts into scalable, equitable systems. We have engaged with over 50 global partners already who have contributed to this platform designs, and we will continue, particularly to work with our lower middle income country partners to ensure that the strategy aligns with the needs and the gaps that exist with them today. It is also supported by a core coalition of the preeminent global health and global cancer organizations in the world, and we're very, very grateful for their support as well. We also have the benefit of the hindsight of the lessons learned through diseases such as HIV, TB, and malaria, and also COVID. And we also now have the foresight to be able to build something new and different and impactful from day one. And this platform will serve as a test bed for more inclusive global health models. So we want it to be shaped by the lower middle income voices and the experts on the ground, designed for cross-sectoral alignment and really grounded in equity, transparency, and accountability. So this is our call to action. We don't need to wait for another commission, another conversation, another roadmap, another missed opportunity, another life lost. We have the pathway, we have the partners, we have commitments, we have enthusiasm. And now what we need is that bold investment that we can build this first ever platform to close this cancer equity gap, starting with women, but of course, ending with millions of lives saved in the future. So with that, Vivian, I want to just thank our partners who have been so incredibly important in this work, and we're still building on this effort, so many, many more to come. But thank you for this opportunity to provide this brief remarks of the Global Cancer Fund, and I will stop sharing here and turn it back over to you.
Thank you, Dr. Young. As always, you're amazing. And by the one thing about Dr. Young, she gets things to the finish line. So we're happy to just have her as a, as a team member for this, because we need the expertise and the connections and really the what's it called? When somebody has that vibe, I'll use the slang vibe to get things done. But thank you again. We have Ambassador now. If somebody could please get her as a panelist, that would be great. Our tech support, please help us get her as a speaker so we can get her remarks. And but as I mentioned before, this has been a conversation that didn't start today, but we're just, as we wait for her to get on, we're just going forward to say, okay, how can we translate the previous conversations we've had from previous engagements, whether it's through research, the summits around healthcare financing? How can we create a system where we, as the consumers of healthcare, as diaspora, can contribute and see ourselves as investors in healthcare, and not just people who just give money without a structured way? So with that, Ambassador Kakonge, I hand this over to you.
Good morning, everyone. I just wanted to say a quick thank you, Vivian, and asking for your patience. There was a little bit of change in my schedule, so I'm in motion. So if you don't mind, I'm going to, so that not to make everybody dizzy, I'm going to turn off the video, but go ahead with my remarks, if that's okay. And I'd like to say a big thank you for the previous speaker. Indeed, a lot has already been laid. The foundation has already been laid, so we don't have to repeat many new things. So can we pick up where we are and build a platform with what we have? I think that's really practical.
All right.
Okay, so we're ready to go. In that these are my remarks. Of course, that the official thing that I have to read and present. So here we go. Good day, everyone, to all our esteemed guests, colleagues in global health, members of the diaspora, and friends. Thank you for joining us for this important conversation on financing cancer control. It's truly an honor to be here with you. This webinar builds on the incredible energy and ideas shared at the 2025 Global Health Catalyst Hope Summit at MIT. We continue to make momentum to tackle a critical challenge on how to sustainably and equitably fund cancer care across Africa. Africa carries a heavy burden when it comes to cancer, but our health budgets are stretched thin. In Uganda, public health spending has actually could do much better than we usually anticipate. But here's the opportunity for the diaspora. In 2022 alone, Uganda's living abroad sent home over 1.3 billion in remittances. That's more than 4% of our GDP. These funds are already helping with education, health, and basic needs health systems. What if we could change that? Imagine if some of those remittances were channeled through smart, secure tools like health bonds, digital wallets, or blockchain-based remittance platforms, so that every dollar sent could go even further. We're not talking about the theoretical solutions. These are actionable, scalable ideas that can be directly supported by cancer programs, expand infrastructure, and even help Uganda join a future global cancer fund. Uganda is a strong position to lead on this. Our national development plan already emphasizes the need for diaspora involvement, domestic financing, and public-private partnerships in healthcare. And through collaborations with partners like Global Health Catalyst, the Ministry of Finance, and the Bank of Uganda, we can bring these ideas to life. One exciting example is the Comprehensive Cancer Center in the Cloud. This initiative, powered by AI and cloud technology, will connect Ugandan doctors with global experts, enable remote diagnosis, support training, and improve how we can manage cancer data. But more importantly, it brings care closer to patients, especially in rural areas where access is limited. And yes, funding such a center is not just charity, it's an investment in the survival and dignity. To make these tools work, we need strong leadership from our financial institutions. The Ministry of Finance and the Bank of Uganda have a key role in creating the rules and systems that will make remittance-linked investments transparent, secure, and aligned with national priorities. We also need tech companies and telecoms on board to make these platforms user-friendly and accessible, even to someone sending money home for the first time. As we gear up for the UN level high meeting on NCDs this September, today's discussion could be more timely. We cannot rely on aid alone.
Ambassador, we can take a minute.
Yeah, we cannot rely on aid alone. We need to mix funding from the state, from global partners, and from citizens, especially diaspora communities. This is my last paragraph. So let's take this moment to align around a shared goal to unlock the power of diaspora capital, build cancer programs that are grounded in local needs but globally connected, and make Uganda a model for what's possible in Africa when innovation, technology, and community come together. Thank you for bearing with me. Sometimes I get a little bit of an allergic reaction to air conditioning. But thank you so much for listening. And this is such an exciting opportunity for really for public health, and also to just take that initiative and to work with partners. So we look forward. Thank you.
Thank you, Ambassador. And even though your schedule has shifted a little bit, it's great to have you engage in whatever format that is possible. And we hope that we can still have you on in the background because your input is very critical, especially when it comes to policy and US-Uganda engagement. But with that said, we have—
Yes, I'm with you all the time. I'm here in the background. Thank you, Vivian.
We love to hear that. And we also, our next speaker is, as we wait for PSST, who is Dr. Jackson Orem. I think many people in oncology know Dr. Orem for the incredible work that he does. I first met him in person in 2023, and his warmth and was just something you don't get often in the health sector, especially among professionals. But it was a testament to who he really is as somebody who is seeking partnerships with everyone. So he's a leading voice in global oncology, currently serves as the director of the Uganda Cancer Institute, and his visionary leadership has transformed UCI into a continental center of excellence in cancer research, education, and clinical care. Under his direction, the Institute has significantly expanded its research and clinical infrastructure, forged impactful international partnerships, including with the GHC, and advanced equitable access to cancer services across Uganda and the wider region. So he's instrumental in really developing collaborative training programs, strengthening Uganda's oncology workforce, and setting really benchmarks in capacity building. And his voice today is very critical in the sense that as we're talking about funding infrastructure, funding systems, he is really at the core of the cancer control program in Uganda. And so if he understands the challenges with equipping the medical centers or cancer institutes, and also the struggles that patients go through to fund care. So his voice is it will be very insightful and impactful in helping shape a funding mechanism. So over to you, Dr. Orem.
Thank you very much, Vivian, for a wonderful introduction. And I want to take this opportunity also to acknowledge the presence of Ambassador Robi Kakonge and my colleagues, the panelists. I also, in a special way, want to thank Catherine for that presentation. I'm singling that out because I joined when she was making her presentation, and I kind of joined late because of some technicalities, but I'm glad that I am here on the program. I also want to warmly welcome my fellow panelist, Chris. I'm so glad to see you and to looking forward to hearing what you can say. I thought the remarks that were made by Catherine was very, very eye-opening in this conversation. And I'm so happy that, there's something like a global cancer fund that is being muted. And I think this is long overdue. As you know, on our side, I think the biggest challenge that our population face is that of financing. And this is because cancer care or cancer control for that matter is not just something which you can just do without a lot of investment going into what is required to provide or to undertake an effective cancer control, especially at a national level. And of course, because of that challenge, I want to say our leadership here in the East African region decided to kind of come up with a mechanism that is a bit different, and that of trying to pool resources together. And this was informed by the observation that there's a lot of flight of resources, name it capital, from the region for care for the non-communicable diseases. Of course, the foremost of these would be cancer. And when a study was done to understand exactly why is this the case, it was realized that the main reason why people are going out of our region to seek care elsewhere were basically two. Number one is because we do not have the infrastructure, name it equipment or anything that actually would provide those type of care within the region or within our countries. And then number two, that there are no experts in the region that can actually meet the needs of this population. So as a result of that, they just go around, they go outside of the countries and also outside of the region. And what follows them are the resources, the little that there is within the region or which has been accumulated by our countries are actually taken away by those who go to seek for care outside. And that leaves actually the poor without any support, without any care. So then the leaders of our region came up with the question of why should we not put our resources together and then have what we call centers of excellence to kind of manage these conditions, the non-communicable diseases, be it diabetes, hypertension, cancer, heart diseases, etc. And what came out is what we call the East Africa Centers of Excellence. And Uganda happened to have been chosen to be one of those centers of excellence, especially for oncology. And I think that's the reason why the Uganda Cancer Institute is very important for a discussion like what we are having right now, because this center of excellence for the East African region actually sits within the Uganda Cancer Institute. And then the other countries have other centers. For instance, for kidney diseases, the center is in Kenya. And then for cardiovascular diseases, the center is in Tanzania. And then Rwanda has another center, and then Burundi and many other countries they do have. But all these centers are still in development. Why am I bringing this here in this discussion? It is simple. The reason is that for us to galvanize resources, be it from our own treasury or from donors or even from the diaspora remittances that we are actually talking about, there must be systems in place. And these systems should be such that it is not only within the national countries, but within region, in order for it actually to be able to meet the needs of the various population that we have. The reason is simple. If you come to our center here in Kampala, you'll be amazed that actually there are all people from all over the countries around, be it from Sudan, Congo, Eritrea, Ethiopia, all of them are here. They are because the countries are linked. That means actually the resources that we use within the region serves an extensive population. So, in as far as the diaspora is concerned, you'll realize that these remittances are sent to the different populations, and that means that if they are to make sense, there is need for us to consolidate them. And I think that is why an example like what is happening here in Uganda is very important. So that's number one. And then number two, apart from the centers of excellence, within the country, we do have what we call the National Cancer Control Plan, which actually has everything of a plan, including actually the budget or the estimates of how we can implement it. And what is now lacking is mobilization of resources for getting it actually implemented. And then, of course, the third point is the fact that there is quite some substantial investment in infrastructure that is being already done by our government. And there is need for us to kind of see how we can sustain this. And then, of course, there is also the element of need for innovation as well as research. And in this, the point that Ambassador Kakonge was bringing about of the virtual cancer control or National Cancer Control Center, or you can call it a system which can actually virtually be used for provision of care, even in remote areas, would be actually one of those type of innovation. So in conclusion, what I can say is that there is need for funding, there are plans, and there are also ideas that actually need to be supported. And something like what we are talking about here could actually be the starting point for such. I want to hand it over back to you, Vivian. Thank you.
Thank you, Ambassador. Oh gosh, thank you, Dr. Orem. You are an ambassador in oncology, so you do amazing work globally. So you are indeed our ambassador. I've given you the title officially.
Thank you.
But no, thank you so much for your remarks. And again, you do incredible work in oncology, not just in Uganda, but regionally and globally through your shared research. And, part of what you're talking about, the need for consolidating programs, the need for consolidating funding, or it's really why we're here today. And you mentioned that you have there are some ideas. So one of the goals, and which we'll get into later today, is to see how those ideas can feed into or contribute to creating a system where they can be implemented through a model, especially for Uganda. But before we get into that, and we'll come back to all of you later in a panel conversation around this. But our next speaker is Evans Biabazede Chua, and please, I'm sorry if I mispronounced that, but Evans is a financial market professional with over 17 years of experience at the Bank of Uganda. For those who don't know what Bank of Uganda is, it's Uganda's central bank. So her expertise spans financial market development, public debt management, and monetary policy. Her work has also been pivotal in building efficient and inclusive financial markets in Uganda, enhancing investor confidence and market transparency. She's a respected policy advisor and she's provided technical assistance to regional central banks and served on numerous financial market committees. She is a strong advocate for financial inclusion and is a certified financial literacy trainer. I say this with a smile because we have so many people in financial literacy as our attendees, including one particular friend who we reached out to at some point as we were coming up with this programming, Derek, and there's a whole team in Massachusetts of Ugandan diaspora in financial literacy. But with that said, they'll be happy to hear from you. Over to you, Evers.
Thank you so much, Vivian, for that warm introduction. And good day to all our panelists. I know there's some abroad and some in Uganda, so I will just say good day. As been introduced, my name is Evers Byabazayirechwa with the Financial Markets Development Department in Uganda. So I'm really happy to be a part of this conversation. I'm representing the Bank of Uganda. And this is very important because at this stage, we are looking at developing our financial markets, and our diaspora bond is something that we've been thinking about for quite some time. And as highlighted in the budget speech by the Minister of Finance this year in June, he did mention that we're moving away from over-reliance on conventional borrowing, and we're looking at other areas. He mentioned the Sukuk bonds, the diaspora bonds, and a number of bonds. So this is very, very important for us at this point to be a part of this conversation. So as we mentioned earlier, and I think it was the ambassador who did mention, we've recognized the diaspora as a vital source for national development. And we've seen the remittances really growing from about, it's about 75% from 2011. We are now at 1.4 billion. That was the last figure in June 2024. So this avenue is really being looked at as a good way to help with national development. So how can we then channel this private wealth into productive investments for our nation? So we recognized this a while back. So in 2012, there was a feasibility study that was carried out to establish how feasible it would be to carry out an international diaspora bond by Uganda. But at that time, we noted that we lacked critical mass. And so it was then agreed that we would have a two-phased approach. One would be having the local currency bond with a diaspora component, where the diaspora can come in, we allow them to invest. And so we've done a lot of sensitizing of the diaspora in order to attract them into the local currency bonds. Then phase two, once we built critical mass, then we would get into having the international diaspora bond. So what we've also done is look at other countries that have had these diaspora bonds. We've noted that in Africa, some have not been as successful. As you know, there was one by Ethiopia. It was undersubscribed. It was for the dam. But Nigeria is a good success story. At least they had a well-subscribed auction. And so that has been very helpful. So those are the countries that we look at, but also outside Africa, India, Israel, very successful. So what have we learned from these countries? One, we've seen data is very, very important. So having a comprehensive database would be very important because you would know that the diaspora out there, how many are they willing to, what do they do, what is their potential in terms of financing. So those are very important. So it would be good for us to build an official record. And I know that the President's Office and Ministry of Foreign Affairs have been working hard to ensure that they have a database for the diaspora. So I know this is being done by different missions. So that would be one of the areas that would be critical. Then, of course, it would be good for us to have a clear and transparent purpose. And we're discussing one here, health. So these bonds, I know the diaspora won't want to invest in the bonds that we issue all the time, the plain vanilla bonds, where all the money goes into the consolidated fund and is used for different, for budget support. But if this bond is tagged for something specific like health, cancer, Dr. Riem was talking about, all these things, the reasons why issues around infrastructure. So we could channel that into infrastructure tied to health. So that would be very important. And I know it would also appeal to, the diaspora's philanthropic motivations because they have ties back home. They would like to ensure that their family well-being. And just to mention that when we consider the remittances, the 1.4 billion I was talking about, the remittances we saw last year, most of them are channeled to consumption. So this would then, if we could tap this for investment purposes, I'm sure that number would increase even from the 1.4 and really shoot up. So then the other thing that we've also learned, just looking at those that have carried out this bond, is of course institutional capacity and trust. That's very, very important because the diaspora won't invest if they don't trust. And I think that's another reason why the Ethiopian bond was not very successful at the time. So it's important that we're able to build trust. We should have transparent reporting, and especially on the use of the funds. Then, of course, we would need to have a well-structured product. So if we're doing hard currency, and I know because of that conversion, it would be important that this is an international bond in a hard currency, as opposed to maybe the Uganda shilling. So there are a number of considerations. But then what has Uganda done? Since I mentioned that the feasibility study was done in 2012, what have we done? Yes, I've mentioned earlier, we've had many of these sensitization drives trying to appeal to the diaspora to invest back home. And so the other thing is we're working on a national diaspora policy. Why is this important? It would help us define who diaspora are. Would it be 3 generations if your parent was Ugandan, 3 generations down the road, or are you married to a Ugandan and you qualify for diaspora? Or have you just gone to maybe Kenya for 3 weeks and you're diaspora? So it would help just give us some clarity. Also, it would be important for us to know how to engage the diaspora. So that engagement is very, very critical. So that diaspora policy is very important. There's a draft right now that Ministry of Foreign Affairs is working on, and they are hoping that this financial year it will be launched in one of the diaspora forums. So that's important. Then the other thing that we've done since is an online investment system, because when you think about it, yes, we say now we want to issue a bond. How will the diaspora then invest? So because we're looking at our retail investors really from the diaspora, we would like to have a system that you can use, even mobile money, because now we are trying to introduce a project called Okusevinga that will allow for Ugandans to invest in government securities using their phones. So now that we are developing that infrastructure, we would also like to leverage on that to be able to have the diaspora also use that. So that's at least progress that we have. We're thinking about that, seeing how best the diaspora can invest as well. Then, yeah, we're looking at diversifying the instruments. As I'd mentioned before, the minister had talked about this. So there are a number of bonds that we could issue. There's Sukuk bonds, there's green bonds, social bonds, and this particular discussion we're having, what comes to mind is a social bond. We can have a social bond and really tied to health, so to healthcare projects. So what then would be our recommendations coming from this discussion? We'd think about updating that feasibility study that we had in 2012. Then, of course, we would need to fast track that national diaspora policy and see if there's anything from such discussions that would be critical to include in that policy. And then, yeah, we would continue with these sensitization campaigns. It's important for us to have an efficient mechanism to communicate with the diaspora. And of course, I'd mentioned earlier, transparency is very, very critical, how we are going to use the funds. So there'll be some sort of reporting, monitoring, accountability for usage. And so there's a number of things we can do in that space. So I'd like to stop here, but maybe just one critical one that we've also seen from Nigeria and from Israel. We saw that they registered with the US Securities Exchange Commission. So that's important for them to register. It allows for that credibility with the bond. So we're thinking that would be another step. But also just studying from Nigeria, we saw it took them about 4 years. So yeah, those are some of the things we could do just to enhance that. And of course, regulation, we look at regulatory enhancement. We can work with Capital Markets Authority on that registration just for investor protection and anti-fraud. So thank you very much. I'd like to stop here, Vivian, otherwise I'll talk all day.
That's why we got you here, to give us as much information as possible and your expertise. But thank you for at least the introductory remarks, and we'll be coming back to you later to engage more in detail. And This is a great time to transition, so we're still waiting on PSST. Unfortunately, it's not. We haven't yet seen him on the platform, but hopefully he can join us. But in the meantime, we'll just keep this going, especially since we have representatives from the government already. The Bank of Uganda and the ambassador is still on with us. So our next speaker is Mr. Chris Muflon. And he is, just 1 second, I need to get my, yeah, all right. Just getting reorienting myself. And so Chris is a healthcare finance strategist at the Global Health Catalyst. He has over 13 years of experience in financial modeling, portfolio analysis, long-term roadmap design, securities trading, regulatory compliance, and risk management at JP Morgan Chase and Bank of America. Before that, he had 7 years of experience in microfinance in Africa with the German Development Agency for International Cooperation, which many of us knew as GTZ at the time. But he is an internal person who is really driving this conversation, helping navigate these the conversations to create a platform or a model that could work for remittances. But this part of this process is we want to hear from every one of us as stakeholders. Would the framework that he has researched, would it work? And if so, how can it work? If not, what could work? So over to you, Chris, to just share a framework of what you have researched in terms of how diaspora can meaningfully invest in healthcare in their countries and also in a global cancer fund. Over to you, Chris. While we're waiting for him, I would like to prepare the panelists that after his presentations, we'll be getting back to you to ask your feedback on some of the frameworks that he's pointed out or that he's presented to see if that could work for a country like Uganda. But also in the meantime, as we wait for Chris, if any of you have any questions from the audience, please use the Q&A. We don't have the chat function yet because of technical issues, but please throw your questions to the Q&A based on the previous conversations, and then we will deliver them or ask them to the relevant people as we go along. Thank you. Chris, are you ready for us? You're muted.
Yeah, thank you so much, Vivian. And just 1 moment, let me load my slide here. Okay. Thank you again, Vivian, for this opportunity, and welcome everybody. I will examine the diaspora's impact through the lens of healthcare finance with a focus on Africa. But first, why innovative health finance? Well, as you can see on my screen, according to World Bank and IMF estimates, Africans in the diaspora sent over $100 billion in remittances to the continent in 2024. Evas mentioned about 1.4 billion to Uganda. So these flows are larger than all official development assistance and often really exceed foreign direct investment in many African countries. So this is really significant. However, remittance flows are fragmented, making it really challenging to harness their full potential for positive impact, especially in healthcare. To achieve universal health coverage, which many African countries are really pursuing, the WHO and African Union estimate that countries need an additional $15 to $20 billion per year in health infrastructure and systems investment. This includes capital for diagnostic equipment, cancer centers, health workforce training and retention, supply chain systems, and digital health infrastructure. As you can see, additionally, about $10 billion in official development assistance for health in Africa is mostly project-based or restricted. Very little flexibility, meaning that most donor funding comes with tight conditions, narrow scopes, or short time horizons that limit flexibility and long-term system impact. Yet, most African countries underinvest in health, allocating only 5 to 7% of their national budgets, far below the Abuja Declaration of 15% target. So, what's the key insight here? This means if even 10 to 20% of remittances were redirected into innovative financial vehicles, such as diaspora bonds, vouchers, that could really close the gap that we're talking about. That's the key here. So we are going to look at exactly how that can be done. And so what is health security? Because basically what I just talked about is about health security. And how can innovative finance really help meet this need? So health security really means the capability to prevent, detect, and respond to public health threats. So established donor models, like I've mentioned, may not meet current needs. Therefore, African countries need to consider new methods for financing and maintaining health system resilience. And by integrating innovative finance with insurance, households are protected from catastrophic health spending and improve system-wide resilience. Education and faith partnerships foster trust, while behavior-linked key performance indicators promote community engagement. So diaspora health bonds, voucher-linked bonds, philanthropic vouchers matched with impact funds offer new ways to achieve health security, and technologies like artificial intelligence and blockchain offer new solutions to boost whole person health, prevention, early detection and treatment, and future cost savings, saving lives, and increasing workforce productivity. But what is meant by diaspora health bonds, as we've been talking about? They are a debt instrument where a credible health institution called an issuing entity raises money to fund health infrastructure by borrowing from diaspora investors for a predetermined period. Diaspora investors earn social and/or financial return from the money lent when predetermined outcomes are achieved. The amount lent is returned to diaspora investors at the end of the predetermined period. It's like lending strength to your community's health system with impact and accountability. Another innovative financial vehicle is a voucher-linked bond. What is it? It is a debt instrument that bridges the gap between financial investment and social benefit, aligning the interests of diaspora investors, recipients, and national development priorities. So diaspora members or donors purchase digital vouchers or electronic codes used to redeem value that guarantee access to specific health services, such as cancer screenings, diagnostics, or treatments for individuals or communities. These vouchers are then aggregated and bundled into a bond, which is issued by a credible health institution. The bond attracts additional capital from donors, investors, or insurers, enabling broader service delivery and health system strengthening. Let's walk through how diaspora health bonds and voucher-linked bonds differ, yet both play a crucial role in health financing innovation. Let's look at investor appeal. Diaspora health bonds primarily attract diaspora members who are looking for a mix of impact and financial return. They want to know their funds are making a difference and may also be repaid with interest. Voucher-linked bonds, however, appeal not only to diaspora, but also to local donors and philanthropists, especially those who want guaranteed service access for specific individuals or communities. It's a more direct and emotional anchored offering. How does the capital come in? In diaspora bonds, the capital comes in through direct investments into a bond, usually in larger amounts. With voucher-linked bonds, the capital begins as prepaid vouchers, for example, for cancer screenings, diagnostics, or antenatal care. These vouchers are then bundled into a pooled investment vehicle, forming the basis of the bond. How about the primary beneficiaries? Diaspora bonds are typically used to strengthen health systems at a broader level, such as financing equipment, infrastructure, or national programs. Voucher-linked bonds, in contrast, offer guaranteed services to a named or anonymous beneficiary. It could be your mother, cousin, or a rural cancer patient identified through AI triage, ensuring a personal and visible result. How about tracking? With diaspora bonds, impact dashboards show broad key performance indicators and financial performance. Voucher-linked bonds offer real-time service tracking. Every voucher redeemed is tracked, whether it was used for a screening, diagnosis, or referral, ensuring accountability and data for bond payouts. There is an emotional anchor in this. For diaspora bonds, the appeal is to the community-wide population, the pride of it, supporting national health outcomes. For voucher-linked bonds, however, they create a tangible emotional anchor. It's about knowing your voucher helped someone get diagnosed early or access life-saving care. It's philanthropy you can trace and feel. Now, the third innovative financial vehicle is a philanthropic voucher. A philanthropic voucher is a standalone voucher not linked to a bond, purchased by a donor or diaspora member to guarantee a specific health service for someone in need, just as I explained in the previous slide. This is targeted giving. You are not just sending money, you are sending care. Now, after examining three innovative financial instruments, the question arises as to how one might allocate, say, 2%, 5%, 15%, 20%, or more of annual remittance flows into diaspora health bonds, voucher-linked bonds, or philanthropic vouchers, should they decide to do so. It is through a digital platform or marketplace on which the innovative financial instruments are bought, tracked, and redeemed after being listed. It's where diaspora investors, donors, health, and finance institutions can converge, view verified data, and support healthcare transformation through secure and measurable financial vehicles. So, Just imagine a platform that is a Bloomberg terminal meets NASDAQ, but for HERF bonds and vouchers, merging real-time HERF data with capital market functionality to democratize both capital and insights. Just like a Bloomberg terminal in financial markets empowers investors with data, and the NASDAQ connects them to markets, a digital platform for HERF-focused bonds and vouchers does both, powered by AI, blockchain, and African innovation. An example of a digital platform is the African HERF Bond Exchange, ABEX, which is imminent. What are the technologies that power a digital marketplace for innovative HERF finance instruments? The first set of technologies is the Comprehensive Cancer Center in the Cloud, C4AI. The C4 is developed by Global HERF Catalyst as a transformative platform to deliver end-to-end cancer care services remotely that include whole person health, diagnosis, triage, referral, treatment planning, and follow-up. The vision is simple but powerful. Make it possible for any clinic, such as the Uganda Cancer Institute, Health Post, or even mobile device to become a part of a virtual cancer center, supported by cloud computing, AI, blockchain, and data analytics. C4AI adds incredible value across the board. For diaspora investors, the C4AI means smarter, safer investments. The platform helps to pinpoint where the needs are greatest, like detecting cancer hotspots. So their capital targets regions where both health impact and returns are maximized. Plus, diaspora investors get real-time dashboards tracking health outcomes, financial returns, and economic gains. It's visibility they have never had before. For bond issuers, C4AI eventually helps with structuring bonds in ways that are data-backed and outcome-focused. Issuers can forecast the impact of their bonds, align with national health priorities, and allocate resources more efficiently. For health providers, C4AI eventually forecasts patient flows and disease trends so they can plan staffing, supplies, and infrastructure effectively. It also monitors quality and helps providers optimize services, which enhances the financial sustainability as they serve more patients through vouchers. And importantly, for patients, C4AI eventually identifies underserved communities, enabling targeted outreach and equitable access. Patients are also benefiting from personalized care pathways, ensuring they are triaged and guided to appropriate services quickly and efficiently. In short, C4AI is the intelligence engine behind a digital marketplace, making sure capital flows where it matters most, risks are mitigated, and all stakeholders, investors, issuers, providers, and patients benefit from a smarter, more responsive health financing ecosystem. This is how we ensure that every dollar and every voucher is not just spent, but strategically invested in Africa's health resilience. The second set of technologies that power a digital platform for innovative health finance instruments is blockchain. This visual summarizes how blockchain technology delivers distinct benefits to key stakeholders, creating a system that is secure, transparent, and efficient. For diaspora investors, blockchain provides full transparency. They can see where their funds go, track performance, and measure impact in real time. Trust and security are built in. Every transaction is immutable and verifiable. Through smart contracts, capital is only released when key performance indicators are met and verified. For bond issuers, blockchain enables efficient issuance and tracking of bonds, reducing costs typically associated with intermediaries. It ensures regulatory compliance and auditability, with all transactions and records easily verifiable. This system boosts credibility with global investors, making African-issued health bonds more attractive. Healthcare providers benefit from instant and guaranteed payments when services are delivered, thanks to automated triggers in their smart contracts. This reduces administrative burdens, less paperwork, more time for patient care. Being part of a transparent blockchain-based system also gives providers a reputation boost, attracting more patients and funding. Patients gain through voucher traceability. They can trust that the care they are entitled to is fully funded and validated. Blockchain facilitates faster service access because providers are incentivized by immediate payments. Plus, with data privacy and consent protocols, patients retain control over their information within a secured framework. Ultimately, blockchain is a digital platform that provides us with the trust engine that we need, seamlessly connecting capital, care, and data, ensuring that every actor, from diaspora investors to patients, benefit from a secure and transparent ecosystem. What strategic values do these innovative health finance vehicles hold for the Ministry of Finance, Planning and Economic Development and the Bank of Uganda? Well, the Ministry of Finance, Planning and Economic Development is crucial to Uganda's health and development. Voucher-linked bonds and philanthropic vouchers can act as transitional financing vehicles as Uganda's national health insurance scheme matures. Diaspora-driven non-traditional financing can boost Uganda's Vision 2040 and National Development Plan by building human capital and reducing disease burdens, both of which are foundations of a productive economy. All right, so this is basically what these two institutions benefit from blockchain. And one more thing, these instruments can really attract partners, improve investment appeal, and establish Uganda's leadership in innovative health funding. Now, the Bank of Uganda is positioned to really support developments in financial innovation and regulatory practices. By participating in innovative health financing, the Bank of Uganda may contribute to the establishment of a digital bond market for health that corresponds to its objectives regarding financial sector stability and capital market development. And blockchain-enabled health bonds and vouchers issued via a digital platform provide regulated and traceable instruments intended to mobilize diaspora capital, supporting goals around financial inclusion and digitization, and may be considered for central bank sandbox or innovation pilot programs. Now, how do innovative financial instruments help diaspora capital work more efficiently? Here's an example to illustrate how structuring and stacking a voucher-linked bond works for impact. Let me focus on a voucher-linked bond in this example. So imagine that a credible health institution issues a voucher-linked bond. The bond is structured by blending it with other sources of capital in a stack. Diaspora contributions to the bond are matched by other sources in alignment with risk tolerance, diversifying the capital stack to improve financial stability and impact. In this example, philanthropic grants are placed at the bottom layer to serve as the foundation of this financing structure. They provide the first loss capital, absorbing any early risks or shortfalls. The government is the second layer that contributes with health infrastructure, staff, and patient databases. In this example, this layer isn't cash, but it's essential for making sure diaspora financial capital translates into real health service outcomes. Now, Interested impact investors with moderate to high risk appetite are placed in the accelerator layer. Impact funds in this capital stack play a catalytic risk-tolerant role designed to attract other investors like diaspora members, private capital, or development banks by absorbing early risk, offering guarantees, or providing matching capital. And the voucher-linked bond is placed at the top of the stack to provide the main funding for direct services such as AI triage, diagnostics, and treatment. As you can see, diaspora investment is protected by all the layers below. So imagine this stack as a building. Philanthropy is the foundation that absorbs the shocks and stabilizes the structure. The core pillars of the building are government and impact funds. They keep everything operational and upright. The roof is diaspora capital. It is protected by everything below, enabling outreach and service delivery at the front lines.
As we wait for the next slide, I just wanted to very quickly interject to recognize that the Permanent Secretary and Secretary for Treasury for Uganda is here as a panelist, so he's in attendance. Welcome, Mr. Ramadan Golbi. It's a pleasure to have you here. Sorry for the interruption, Chris. Just wanted to acknowledge that.
Thank you, thank you. So now, what you see on your screen now is an example to illustrate how an impact fund can make an impact in Africa's health financing. I'm just picking up from the stacking that I showed in the previous slide. So Great Lakes Sustainable Capital, it's a made-up name. It's an institutional investor in Toronto, Canada, and aims Pan-African health exposure. So they lock into a digital platform for African health finance and see a dashboard of standardized vetted bond listings, including yield, maturity, credit enhancements, use of proceeds, risk mitigation instruments, and impact key performance indicators for Uganda, Rwanda, Mozambique that have pulled together their resources, and Nigeria bonds. The team evaluates these bonds, considering a diversified $3 million allocation as shown in the pie chart. In this example, it is assumed that the Global Cancer Fund participates in bond validation, possibly by purchasing a tranche or offering credit enhancement to the Uganda Diaspora Health Bond. As a result, this increased investor confidence and credit worthiness as the Global Cancer Fund's involvement signals that the bond has been de-risked and vetted. Consequently, Great Lakes Sustainable Capital allocates funds into the Uganda Cancer Bond as part of a diversified health impact portfolio. What's the key takeaway here? The Global Cancer Fund's participation transforms a Uganda diaspora backed bond into an investable, trusted global asset. To strengthen global health security, we must go beyond bricks and beds. People must be informed, empowered, and willing to seek care. This is where behavioral finance innovation becomes critical. Bundled cancer access bonds can earmark funds for community outreach, education, and behavioral interventions, all essential in combating delays in diagnosis and treatment uptakes. By embedding behavioral key performance indicators, such as screening awareness rates or referral follow-through rates, we ensure that bond payouts are tied to meaningful, people-centered outcomes. This protects both the investment and the public health impact, aligning financial innovation with long-term health resilience. Now, how does capital in innovative health finance vehicles flow in a digital platform? Imagine that a diaspora health bond is structured to directly finance the development of cancer infrastructure in an African country. The process starts when diaspora members log onto a digital platform and select to buy diaspora bonds that are specifically designated for cancer infrastructure. The funds from the bond purchased are then pooled into a dedicated cancer infrastructure fund on the platform. These can fund the construction of a cancer center, imaging and diagnostic facilities, or radiotherapy units, for example, organized by country and risk profile. Next, the funds are disbursed to accredited project developers, construction firms, or through public-private partnerships that will actually build the facilities. Importantly, the disbursement of funds is tied to verified milestones, such as completion of site preparation, equipment installation, or facility accreditation. The platform leverages C4 AI tools and even satellite imagery to monitor these milestones, ensuring transparency and accountability before funds are released through blockchain smart contracts. Once the facility is constructed, equipped, and fully operational, it is then transferred to health providers who begin delivering critical cancer services such as screening, diagnosis, and treatment. As patients start using these services, the facilities begin to generate revenue, either through direct payments, vouchers, insurance reimbursements, or government subsidies. If linked to outcome-based financing in a capital stack, donor-backed outcome funds may top up revenues when specific health targets are hit. The platform tracks all of this in real time, from service delivery to facility utilization rates, and feeds that data back to the investors through the platform's dashboards. Finally, as the facility operates successfully and generates revenue, the bond matures and investors are repaid with returns based on the terms of the bond. So this example allows us to channel diaspora capital into tangible, high-impact infrastructure projects, transforming the cancer care landscape while providing financial or social returns to diaspora investors. That's how a digital platform turns diaspora capital into infrastructure, into services, and ultimately into lives saved. Now, let's look at another example. This time, it's how diaspora investment in health services flows in a digital platform. It all begins when diaspora members log onto a platform. They can choose to buy voucher-linked bonds or directly purchase health care philanthropic vouchers for loved ones or communities. The capital from the purchases is poured into diversified bond portfolios organized by health focus areas, countries, and risk profiles. The capital forms the financial backbone that backs the healthcare voucher issued. Next, beneficiaries receive the vouchers and present them to health providers that are accredited on the platform. Providers then scan the voucher, and C4 AI instantly verifies its validity, the service scope, and the patient's eligibility. Once the voucher is validated, the provider proceeds to deliver the healthcare service, whether that's a diagnostic screening, treatment, or consultation. After service delivery, the provider uploads anonymized service completion details and outcome data back to the platform. The platform's C4 AI and blockchain technology verify that the services were properly delivered. If everything checks out, a smart contract is triggered, releasing payment directly to the provider from the bond pool or the voucher fund. This means that providers don't wait for cumbersome reimbursements, like I mentioned before. They are paid promptly and transparently. All the while, the data feeds into real-time dashboards on the platform, allowing diaspora members to monitor both the financial performance of their social impact. How many patients were served? What outcomes were achieved? And the status of their investments. Finally, when bonds mature and pre-agreed outcomes are verified, diaspora investors received either their financial returns or detailed impact reports, depending on whether they invested for a financial return or for pure social impact. Last example. How does diaspora capital flow in a digital platform to finance professional capacity building? Diaspora voucher linked bonds for training finance scholarships or tuition vouchers for trainees. But here's the innovation. Graduates commit to serving locally for a defined period after completing their training. Once they complete both training and their local service commitment, say by treating a certain number of oncology patients, outcome payments are triggered by blockchain smart contracts. These payments made by governments, donors, and outcome funds are used to repay the bond investors. Graduates may also receive service-based incentives like loan forgiveness, bonuses, or continued professional development support funded through these outcome payments. Investors get social and financial returns. Governments expand their tertiary workforce without massive upfront spending. Graduates grow their careers and contribute meaningfully in their countries. And most importantly, patients gain access to skilled, locally available cancer care. So, through a digital platform, not just infrastructure and health services are financed sustainably, education is financed, retention is incentivized, and entire healthcare ecosystems are fortified. How do diaspora investors keep track of how their capital in innovative health finance vehicles is doing in real time? Through a dashboard on a digital platform. Here's a simple example of an AI triage bond investor using a digital platform's diaspora investor portal to track both their bond stage and impact. David can see exactly what stage his bond is in, how many patients have benefited so far, when he is likely to start receiving payouts, that his capital is making measurable health impact. There are some quick actions for David as well to keep him engaged. In conclusion, become an early adopter of innovative health finance. Consider intentionally channeling a proportion of remittances to health infrastructure, diagnostics, outreach, education, and much more. A digital platform provides regulatory compliance, auditability, transparency, and accountability that you've not seen before. And diaspora members can choose to earn a return, reinvest, or just measure the impact. This is next-gen philanthropy and investment. Now, your voices matter, and it's poll time. If we can be able to take a poll, let's take a moment to really hear from you, and your answers will really guide us in building the right instruments and structures that we need. Thank you, and over to you, Vivian.
Thank you, Chris. Amazing as always with your presentations. But I wanted to first let our participants know that the chat is open, but because of some technical issue, those who were on before the chat was open might not be able to access it unless you get out and go back in. But if you don't want to go through that trouble, you can still use that Q&A function. So we have both of them running. We have the Q&A and we have the chat going. And before we get it back into Chris's, exploring what you said, we would like to give an opportunity, I think, right now for Mr. Ramadan to speak to us and share. He is the Permanent Secretary and Secretary for Treasury for the Government of Uganda, Ministry of Finance, Government of Uganda. I'm mumbo-jumbling everything, but it's okay. It's all good. But I would like to invite you, Mr. Ramadan, to please say a word to us, and then we'll continue from there.
Thank you. Thank you very much. I really want to start. I don't know whether I'm audible enough. Can you confirm that You can, very good. All of the distinguished participants, esteemed members of the Ugandan diaspora, the global health leaders who are on this call, the colleagues from government of Uganda, and our gracious hosts at the Global Health Catalyst. My name is Ramadan Gobi. I work as the Secretary of the Treasury for Uganda. I'm sorry for coming in a little bit late. I was on a flight and it delayed. So when it landed like this, I'm not even home. I decided to get somewhere, some space, and I speak to you. It's an honor, definitely, to speak to you on behalf of the Ministry of Finance, Planning and Economic Development of our Republic. I want to begin by expressing my sincere gratitude to the Global Health Catalyst for the organizing this timely and forward-looking conversation, but also to our ambassador in Uganda, for Uganda in Washington, D.C., and that is Her Excellency Ambassador Robbie Kakonge and all your team for championing Uganda's strategic engagement with the diaspora and global partners. Uganda, as we all could be aware, is on a mission right now to build a $500 billion economy by 2040. Among the priority initiatives under implementation for us to deliver this target is the completion and expansion of a range of centers of excellence for tertiary healthcare. And these healthcare centers will serve both Ugandans, but also patients from our region, the Eastern African region, thus widening Uganda's export basket while saving lives. In May this year, government of Uganda launched our Human Capital Development and Growth Review Report, and this is a pioneering effort co-chaired by the First Lady and the Minister of Education and Sports, but also my Minister of Finance, Planning and Economic Development, and it is supported by the World Bank. The report notes that despite having a comparatively lower per capita current health expenditure of about only $57 in 2021 compared to the recommended $112 for low and middle income countries, Uganda's healthcare financing system is more efficient in terms of generating results. Uganda scores a higher health coverage index of about 48%, despite having a lower level domestically financed current health expenditure per capita than when you compare us with our peers in the region, particularly Kenya, Tanzania, and Senegal. The report further notes the rising share of non-communicable diseases in the disease burden on the country's healthcare systems. And these are among the top 10 leading causes of deaths in hospitals in Uganda. And their share of the disease burden on health system has tripled from 8 now to 24% within a decade up to 2022. So Uganda, therefore, is well aware of the increasing urgency to mobilize innovative financing to address these non-communicable diseases, particularly cancer, which continues to place a heavy burden on our healthcare system. Traditional public financing sources alone are no longer sufficient to meet the scale of demand. So we must seek bold, efficient, and inclusive models to diversify our resource base, including market-based financing instruments. Government of Uganda has steadily scaled up our cancer response over the past decade. The budget outturns for direct national cancer response through the Uganda Cancer Institute has increased almost ninefold in the past decade. And in the last 3 years, the approved budget allocations have nearly tripled to now 243 billion shillings. And government has also undertaken to upgrade and establish Uganda Cancer Institute as the East Africa Center of Excellence for Oncology, providing leadership in cancer-related trainings and services in the East African region. And this undertaking has expanded the capacity of Uganda's Cancer Institute to deliver high-level education, clinical training, and research, and has benefited from support of the African Development Bank. When completed, government's ongoing infrastructure expansion drive will add to Uganda Cancer Institute 350-bed specialized cancer hospital, expanding inpatient cancer care by more than 5-fold. And I want to let you know, before I conclude, that we are complementing our modern outpatient with a research laboratory training center through partnership with Fred Hutchinson Cancer Research Center. And this 6-level cancer building comprises an imaging center, clinical laboratory, intensive care, chemotherapy infusion center, and 3 levels of ward space. And by 2026, government had already enacted our Cancer Institute Act. And we have, in other words, the legal framework in place to do what I found Chris trying to explain here. And just last year, government developed our cancer control plan, the National Cancer Control Plan for Uganda, and it provides a strategic framework also for addressing the rising burden, focusing on prevention, early detection, treatment, but also palliative care. We are also emphasizing increasing public awareness about cancer prevention, which is critical. And we feel that we can play a bigger role in the region. Already, Uganda is hosting patients from Djibouti, Eritrea, Somalia, Western Kenya, Rwanda, Burundi, South Sudan, and Eastern DRC, the Democratic Republic of Congo. So UCI, the Uganda Cancer Institute, now attends to a daily average of 200 patients and has rolled out an investment to decentralize its services to 4 regional cancer centers in the cities of Arua, Gulu, Mbarara, and Mbale. So we have these regional also centers. One of them is already operational in Gulu. We are building others beginning this financial year going forward. So our experience, therefore, in building response systems over the last decade have brought to the fore the critical role of partnerships with the private sector, academia, and the global aid system. And we have seen our partnerships actually growing, and this is heartwarming to see that now we are talking, how do we get the diaspora to also participate in this partnership, very noble partnership. I could go on and on, but I thought I should give you that insight, but also to welcome the Ugandan diaspora that is already active in the life of Uganda's economy through the remittances, which have grown to now $1.4 billion as of March this year, to also actively participate as private investors in the growing healthcare business opportunities and our 10-fold growth strategy. We have already targeted it, and we have the frameworks in place to support the diaspora to undertake these kind of opportunities, and also patriotic investment. This is a patriotic investment as you also contribute to the growth of the economy. So in conclusion, I would like to once again thank you, the Global Health Catalyst, for spreading this dialogue and also the Global Cancer Fund Initiative for offering a new path forward. The Ministry of Finance, Planning and Economic Development is fully committed to co-developing these ideas and exploring how we can integrate them into our broader public strategies. The proposals to pilot the use of blockchain-enabled digital wallets that would allow diaspora senders to earmark remittances for health expenditures with the transparency and traceability, they are very much welcome. I will stop there, and I thank you once again. Thank you very much.
Thank you so much, Mr. Govey. And it's so exciting to hear that commitment to say you are committed to partnering on this. I think that's one of the beautiful things about starting this dialogue is, okay, identifying how we can push this to the next level through this continued conversation and remodeling. It's like a design process where everyone's like, okay, who is going to be a part of the design? How do we get this design, finalized and then implemented? But with that, that was a great segue into our, we have now a very short time. We have only 14 minutes to the top of the hour. I wanted to give an opportunity first to previous speakers, to respond to Chris's presentation. Given what Chris has presented, is it something that is viable to Dr. Young for the Global Cancer Fund? How can and in what ways can we move from his presentation to the next phase? And after that we'll go to the other speakers as well.
Yeah, thank you, Vivian, for the opportunity to respond. And Chris, first and foremost, thank you for your incredible presentation where you laid out this idea so clearly. I'm not a financial person, nor am I a tech person, so I cannot talk to the feasibility of this platform. But what I will say is that this is exactly the type of thinking that we want to include in terms of the Global Cancer Fund. It is this type of forward-looking inclusiveness of new technology and ability to attract new funds in new ways that is exactly in alignment of what we're trying to achieve here. I think in terms of how we move forward, one of the abilities that we could potentially help with is bring the right partners to the table, right? So Chris mentioned really attracting the right partnerships, the right tech people, the right minds to be able to build something like this. And I think that is something that we could certainly bring to the table, Chris, as well, to work together on this and make sure that we're moving forward in the right direction altogether. So thank you for this incredible idea, and look forward to thinking about next steps more clearly with you soon.
Perfect. Thank you, Dr. Young. And then I'll just go based on who is on my screen. Dr. Orem, you have really done a lot in terms of research and really not controlling, but managing the cancer control program in Uganda. Based on what the ideas that Chris has presented, how best can we move forward with the UCI to see if, to get the feedback from UCI to continue building on a model like this?
Thank you very much. I should also add my voice really to appreciate what Chris has outlined so clearly. And also, I think to also underscore what our PSST has also stated about the fact that he has actually outlined very clearly the progress that our government has made, albeit with the resources that has been incrementally growing, yet this has mainly been just from our own government. And if there is, for instance, something coming from another source or some other financing mechanism, I think what he stated is exactly what has been on the mind of technocrats like myself, who have been in an area which has been underfunded for a very long time, yet it is very, very vital. So to me, I think what Chris has presented really shows that with technology, and then also new ideas in terms of how we can increase onto what our government is providing. I think, to me, I see this as actually the only way to manage some of these emerging problems, like, for instance, the non-communicable diseases. Specifically, what I want to say is that from a strategic perspective, what our leadership has been doing seems to have kind of been looking into the future. Because as I stated earlier in my presentation and was also reiterated by the PSST, there is need for some of these problems to be tackled from a regional perspective. And to me, I think what Chris presented about the C4 AI as a tool, this would actually be very important if we are to look at the fact that, for instance, most of the cases that we are seeing in Uganda are now coming from the other member states of our regional bloc. That means that this should actually be expanded, and it should not be just looked at as, for instance, a Ugandan kind of issue, but should be looked from the regional perspective. But the Uganda Cancer Institute would be a very good model for cancer, given that already we are seeing the needs are driving the population from the region actually to come and seek care from the center here in Kampala. And then the fact that we are now moving into the population by the creation of the Regional Cancer Center and then having in place our comprehensive National Cancer Control Program means that at a pilot level, the Uganda model or the Uganda Cancer Institute will actually be something that can give the other countries a good insight into how they can actually handle the issues of non-communicable diseases and cancer in particular. So that is actually how I think. What I'm saying is that the Uganda Cancer Institute, given also the legal mandate that it has, and then also the support that is very evident from the presentation that the PSST has given, would be a natural place to test what Chris has presented. Thank you.
And that's what we love to hear, a place to test what has been presented, because that indeed is the next step. Before I forget, and before I get to the next question, I just wanted to remind people that these conversations are going to continue, and the Global Health Catalyst has a summit coming up in September at Harvard. So check out the website, Global Health Catalyst Summit.org, and sign up and be a part of these conversations. And we'll also be having, hopefully, fingers crossed, stakeholder meetings with specific countries and communities going forward. But before I call on, let's get Eva's. Before I ask, there were some questions directed to Dr. Young, as maybe you can prepare as Eva gives us her feedback. They are in the Q&A. So Eva's, over to you. Any response to since you're one of the technical people we have here, to Chris's response?
Yeah, thank you so much, Chris. I'm excited. I was so excited to listen to this, and because it really aligns with what we are doing with market development. And I don't know if earlier in the presentation I had mentioned that we really have support all the way from Ministry of Finance, and the Minister of Finance established a committee which we call the Uganda Fixed Income Market Committee, that's chaired by the governor. It brings together a number of stakeholders in the financial market space, and we are looking to diversify the menu of instruments that we have. So I'm so excited to hear of the vulture-linked bonds, because we were thinking just the diaspora bond. So that's really exciting for me to hear. But maybe just one thing that I should say, and I think maybe Chris spoke about it. Yes, so we have that regulatory sandbox So with these innovations and the AI and the blockchain, what we were speaking to, it will allow for this to be tested in like a controlled space. So for me, yeah, so we're very excited, and in that committee, these are some of the discussions that we can have, and there's space for you to test these innovations in a controlled space. So thank you very much. I'm excited about this.
Evas, not to put you on the spot, but what would be the next step for us to engage with your office? And this it doesn't have to be now, but think about it if you can't give the answer now, but just expressing that we would like to act on that as fast as we can, so that when it's still warm and fresh off the press, and take this really in a very practical setting and figure out how it can work. So is it something you would like to speak to now or later?
Maybe later.
Okay,
maybe later,
perfect.
But yeah.
Perfect.
Okay,
and then we have questions directly to Dr. Young. What are the timelines for the Global Cancer Fund? That's a nice one. Maybe you'll just, yeah, then I think the second one is the projects, about sustainability. So over to you as we.
Yeah, thank you for those questions, and so important. So where we are currently is we've spent the last 8 months or so really kind of distilling down what the scope of the fund would focus on. And of course, that's taken a lot of work in terms of engaging with organizations and experts and people on the ground. So now that we are settling on the stage shifting, launching with cervical and breast cancer, we can now start to pivot towards both the financial mechanisms and the platform, as well as the governance structure of that and what that looks like. And those two pieces will start moving in parallel together. What was mentioned, and the question number 2 was, I mentioned a cohort of pilot countries to begin with, maybe 5 to 7. Those countries have not been identified yet. There will be a number of criteria that are established in order to do that. And that probably will sit under the governance structure that needs to be defined. But we anticipate that if we look at the timeline, that those pilot countries will be selected and announced by the end of Q4 in 2026, and that the actual launch of the Global Cancer Fund would occur in 2027 with the full mobilization of $1 billion by 2030. So that's the overarching timeline of what we're looking at. And then, of course, in terms of sustainability, such a good question, and it is why we want to move away from the traditional funding platforms that we've seen, especially given our current environment that we find ourselves in, the reliance on particular governments for money and funding. We should try to think about innovative ways to not be reliant on that anymore. And so that's why we really want to diversify the way that we are tapping into pieces of funding. I think what Chris has laid out in terms of the diaspora community and all the bonds associated with that he laid out are examples of funding that we would want to include, so that we're not becoming a very reliant model, and so that it can be sustainable every year. We want this to be a very long lasting and impactful initiative for years to come. So I think I'll just stop there in the interest of time, Vivian, and turn it back to you.
Right. I wanted to also give one opportunity to the PSST again to come and share with us what would be the next steps to try and get these really going in Uganda, if PSST is still he's still available. Would love to hear from you before we wrap up.
Thank you very much. Very, very interesting conversation, and I've liked the way it has been flowing. I think Chris made a very good presentation, and much as I came in a little bit late, I realized that we have now a very good opportunity to move forward by mobilizing private financing into our cancer and healthcare well-being all together. In Uganda, I wanted to tell you, In Uganda, we are a bit strict in the way we structure financing for social projects. And also the programs related to social outcomes. Traditionally, we've been financing healthcare, education, social protection, and so on, using mainly concessional financing. The reason is very clear. The payback period for such investments is long term, 30 to 50 years or so. And that's why perhaps Uganda has been very sound in debt management. We are prudent in the way we structure debt, but this is an area where also we want innovations, because these concessional ports are drying up. And we need to ensure that we get new money. But also, as we get this new money, when you look around the diaspora bonds in particular, you find that they are as well patriotic bonds, because they are being issued to patriots, to people who love their country, who would want to make a contribution, but instead of sending their money home through philanthropy just or to their relatives, it can make meaningful and sustainable kind of outcomes. And therefore, I would think that my team at the central bank and us at the Ministry of Finance, working with the experts at the Uganda Cancer Institute, we need to carry this forward by getting global partnerships in especially structuring these new initiatives, and we take this forward. I want to commit here and promise you that we are going to do exactly that. I don't know, did you call Michael? Is Michael online, the governor of the central bank? He's a very big fan of innovative financing, diaspora bonds being one of them. We are also working on green bonds and infrastructure bonds and so on. But I saw, I think, representatives as well of him. So Bank of Uganda, ourselves at Finance, and the Professor Dr. Johnson is online. Our man there, the face of cancer treatment in Uganda and research. We should really carry this forward and be pragmatic in designing bonds which can and other facilities which can attract the financing, because Ugandans out there and other diaspora in the region are very much willing. And as you know, they have already been sending home loads of money. $1.4 billion in this small economy is not very little money. So we shall do whatever it takes to ensure that we can carry this forward. I thank you.
We're very, very encouraged. Thank you so much, Mr. Govi. And yes, the Bank of Uganda is represented here by Evas, who has, and we look forward to taking this the next level. We're going to get to work right after this Zoom. But we've come. We apologize for being a little late. One thing that I think we haven't had a lot of is a lot of the diaspora voice. So part of the next conversation, we're going to focus on inviting you all diaspora, and thank you for turning out in great numbers. And this not only Ugandan diaspora, they're diaspora from all different countries, both in Africa, Europe, Asia. Thank you for being here. To the GHC team, thank you so much for the work that you've put into this. I want to give Chris the final say before to say bye to us. And to Will, by the way, the GHC has 3 directors, co-directors, Dr. Will Ngwa, Dr. Saiful, and Dr. Avery from they're from different institutions. I'm drawing a blank right now, but UPenn and oh my goodness, I'm going to be in trouble. But thank you all for participating and for everyone who came. We appreciate you. Please come to the GHC Summit in September. And we'll also follow our social media. We're going to be sharing on LinkedIn. We post a lot of our updates. I would love you to join the family and continue this conversation. And to other diaspora from other countries, please, let's start organizing as well, so that we have parallel tracks with different countries. We would love for this to be a global phenomenon. And to Dr. Young and Dr. Orem, Mr. Ramadan, Evas, is the ambassador still here? I don't even know. Thank you for your time. Ambassador Robbie, did you want to have a word before we leave? I'm not, she was on the move, so that's why I didn't really call on her. But yes, thank you. Chris, did you want to say something before we say bye-bye? Okay, you were muted, but thank you again. We appreciate you. It's been an honor, Vivian Kopsinger-Birchall, and I'm in this with you all. Thank you and good night.